I'm one of the core surgical trainees from United Kingdom. And today I'm going to present a very interesting topic on eponyms in hernia surgery. The reason why I selected this one, which is not a case report or a series, neither a research, but it was my review article on eponyms in the hernia surgery. It is worth knowing about the pioneers behind one of the very commonly used surgeries, that is a hernia repair. And if we know about how it developed and who all these did surgery, that will inspire us in the future. And not only that, knowing the surgeons is because of them what we are doing now. Maybe in future, if someone reads our name with pride, that will make our success as a surgeon. So here I start on with my eponyms in hernia surgery. Let me just remove the sidebar. Yeah. So the history of hernia repair is the history of surgery itself. It has its mentions to the ancient Romans, Greeks, and Egyptians from the civilization and the images, and to the dark Middle Ages. It has its uses of trusses, taxes for strangulation, and routine excision of even the genitalias. With the Renaissance, the hernia surgery also saw an upstroke in the late 19th century with the initial description by Marcy and Bassini. So here we come on to our first eponym, after Dr. Henry O. Marcy, who was born in Massachusetts in 1837 and was a graduate of Amherst College and the Harvard Medical School with MD degree in 1864. He was the first surgeon who utilized sterilized absorbable suture material in the repair of inguinal hernia, and which was a kangaroo tendon. This brings us to our first eponym in hernia, the Marcy's repair. It is a simple closure on the internal ring with high ligation of cord. And this first herniorrhaphy was performed in the late 1871. And this is the image showing the simple interrupted strings closing the defect. Next, we have Dr. Edoardo Bassini. He is famously known as the father of modern hernia surgery. He studied medicine at the University of Pavia, graduating in 1866 at the age of only 22 years. He has renowned the Bassini's repair. He recreated the natural curtain mechanism of the inguinal hernia, where the contraint tendon of the transverse abdominis muscle and the internal oblique was sutured with reflected inguinal ligament. In 1894, he presented the results of 206 operations with 5-year follow-up of all the patients. None of them had any mortalities. There were only 11 wound infections and 8 relapse cases. Next, we have Dr. William Stewart Halsted. He was an American surgeon born in 1852 and is a founding professor of the Johns Hopkins Hospital. He modified Bassini's technique by repairing the external oblique aponeurosis beneath the spermatic cord. So this is the Halsted's technique. And according to the position of the spermatic cord, Halsted did 2 types of herniorrhaphy. 1, where the cord was under the skin, and 2, when it is repaired under the repair. However, unfortunately, the procedure was not successful due to increased hydrocele and testicular atrophy. Despite that, we will all remember Dr. Halsted for his contribution towards mastectomy surgeries. This brings to the post-Renaissance period. And here we have the very famous Dr. Edward Earl Schulte, who was a Canadian surgeon born in 1890. He had the 4-layer suture continuous running from the inguinal floor to the pubic crest. This was a bit complicated compared to the previous surgeons, as it has 4 layers from the fascia transversalis, internal oblique, transversus abdominis, and external obliques, and starting from medial to lateral, then back from lateral to medial, overlapping each layer. Next, we have Dr. Chestward Bidwell McVeigh. He was born in Yankton in the South Dakota in 1911. He went to the Northwestern University in Chicago and qualified with both MD and PhD with a special research in abdominal wall. Thus, he again modified the same Bassinis technique using Cooper's ligament for repairing this time. This brings to the McVeigh's repair. So he had intrapid sutures from pubic tubercle to the Cooper's ligament laterally instead of inguinal ligament, which narrows the femoral ring. This technique has greater recurrence, however, and hence is seldom used. But since it narrows the femoral ring, it has some benefits in the femoral hernias. Now we land up to the era of mesh repair, which we all are very familiar with. We all use either the ultra mesh, ultra progrip, or the progrip mesh. So the pioneer of developing the tension-free mesh repair hernia, or famously called the hernioplasty, was invented by Dr. Irving Lester Lichtenstein. He was an American surgeon born in 1920. He used local anesthesia instead of general anesthesia so that he can make the patient's cough, so that he can test the strength of the repair while during the surgery itself. So Lichtenstein repair, which was first done in 1898, where he did the surgery in 1,000 patients. So he used the Marlex mesh and not the Prolene one which we commonly use. He used it to bridge the direct floor of the groin without approximating the tissue defect. The mesh was sutured to the inguinal ligament laterally to the rectus sheath and the conjoint tendon above. A slit was then fashioned in the lateral end of the mesh to fit around the emerging spermatic cord. And then the tails of the slits were overlapped around the cord structure at the deep ring. Thereafter, we come to the Reeves-Stoppa repair. In 1975, Professor René Stoppa and his colleague used a large unsutured Dacron prosthesis for repair of difficult groin hernias. He used the pre-peritoneal approach via a low midline incision this time. They used a patch that was 6 to 10 times larger than the area of the hernia defect, and the latter fixation by tissue adhesions and ingrowth into the prosthesis. Hence, there was no suture used for this repair. And as we can see in the image there, he made a cut in the posterior rectus sheath and then placed the mesh in the pre-peritoneal plane. Next, we have the Gilbert's technique. So Dr. Arthur Gilbert was the founder of the Hernia Institute of Florida in 1985. In 1998, he formed the American Hernia Society, modeled after the European Hernia Society. In 1997, he proposed the concept of placing the mesh both in front and behind the hernia opening. He designed thus the bilayer Prolene hernia system. Now we are back to the era of no mesh repair, and this could be possible due to Dr. Mohan Fulchand Desada, the chairman of the Indian Hernia Institute. He completed his bachelor's degree from the BGM Medical School and got his MS degree from the University of Pune in 1972. His famous technique of without using any mesh is famously written down in the medical textbooks of Bailey and Love and Schwartz, as we all are quite familiar with. The Desada repair is a simple tension-free open mesh repair herniorrhaphy done under local anesthesia first in 2001. He showed there was virtually zero recurrence rate and with minimal or negligible post-operative on early complications. Here is the image of the disorder repair. So he used live muscle tissues adjacent to the hernia site to repair and reinforce the weakened area. The external oblique is incised, the spermatic cord and the sac is dissected freely to the way as it done in the previous repairs. The new lower edge of the upper flap is sutured to the original upper edge of the lower flap above the spermatic cord. Thus, there are two layers of external oblique now, one under the cord, as we all can see, and one above the cord, instead of only one layer below the cord. So these are the references based upon which I wrote on my research paper. And I hence end my presentation over here. Thank you so much for listening to me. And if anyone has any queries regarding hernia repair, please let me know. I'm free to discuss on that.